Okay, class, we're going to now talk a little bit about pathophysiology, hypertension. Remember the last video we had was on shock, which is the blood pressure too low, and this is hypertension. However, I want to do two things simultaneously. In your ANP2 PowerPoints, I actually have one called History and Physical Exam, and I'm going to talk on that simultaneously while talking on hypertension. All right, so we want to talk a little bit just to kind of give you an idea, and then we'll quickly go to hypertension, talk a moment or two. All right. When a patient comes in to a doctor's office or a nurse practitioner, physician assistant, the clinician listens to the patient's problems. Now, the symptoms are the patient's problems that they tell to the person. They are subjective. Subjective in that there's no way to truly say if you have pain or not. You tell me that, I'm not sure. Okay? They also may express signs. Signs are something that can actually be seen by the clinician. So in order to make a diagnosis, you combine the symptoms with the signs with some physical exam and some history to come up with a diagnosis. All right. So the way the workup, when you do get into clinical, and you can look at this on your own sometimes, is that when the person comes in, we write down what we call a chief complaint. Chief complaint is basically, why did you come to the office now? What's the reason? Or even, why did you come to the emergency room? So we put the chief complaint. We like to put the chief complaint in terms of the patient's own words, because even if they haven't graduated high school or the third grade, sometimes when you try to massage the words to make them eloquent, you lose the meaning. Then we write what we call a history of present illness. The history of present illness is where we come in and write down what a scenario, a history of what we feel involved in why you came in this time. Not necessarily if you had diabetes because you saw somebody else, but a history of why you came in. Generally, this will be where a doc would say, John is a 27-year-old male who presents with, and then goes into a whole cadre of stuff involving why the patient came in. Okay. Then we go into the past medical history. Past medical history is to see what medical illnesses you had, surgeries, medications being taken now, blood transfusion, allergies. Then we go into the family history. We ask questions about certain conditions like diabetes, cancers, particularly breast cancer, heart disease, things of this nature that may show that there's a genetic predisposition. Then we'll go into the social history. Do you drink, use drugs? How much do you drink? Do you smoke? And so forth like that. Okay. Then we go into what we call the review of systems. The review of systems is where the old way you'd ask a bunch of questions. The new way, and I'm sure all of you have been to a doctor before, you'll have this checklist. And on this checklist, there'll be little boxes. You'll be sitting out there filling out paperwork. You know, it'll start from the head. Have you ever had eye problem? You ever had glaucoma? You ever had this? Review of system, because sometimes when you go to the office, you forget a lot of stuff. So this is kind of a checklist to remind you and see if you had any of that. All right. Then we go to what we call the physical exam. The only things that the person can do, the clinician can do on a physical exam, is visualization. And actually you want to do that first before you even touch the person, because you can disturb things once you touch the person. Then you'll do palpation. That's to feel areas of the patient. Then you'll do percussion, a thumping action to identify organ borders. And then you'll listen to the patient, called auscultation. In the physical exam, the way we write it up, you'll start with the vital signs, height, weight, temperature. Then if this is a physical exam for general practitioner, internal medicine. So in that case, head, eyes, nose, and throat, lungs, you'll listen to lung sounds. The heart, we talked about that. The PMI, see, we remember we talked about that. Sounds, S1, S2, do you have abnormal sounds? The abdomen, we put the stethoscope there to listen to intestinal sounds. We feel extremities of pulses, neurologic. Some will do a gynecologic, and then a psychiatric evaluation, a modified psychiatric evaluation. Okay. Then what we do, we come with what we call the impression of the differential diagnosis. As a result of the findings in the patient history combined with the findings in the physical exam, the clinician compiles a list of possibilities of what she thinks it may be there. And so now with that, that's where we come to the plan. And the plan is you've written a long list, or at least a short list, of differential diagnoses. I think it's anemia. I think it's high blood. I think it's this and that. And then in the plan, you're ordering certain lab tests to rule out certain things that you thought it was. So if you had a list of 5 possibilities, then you would order lab tests that are apropos to either confirm the diagnosis or rule out some. And then the other part of the plan is for the treatment that you will recommend. All right, so that just gives you a quick idea of how a history and physical goes. So we'll go over here to hypertension real quick. Okay, hypertension, hypotension, like a shock deal, is when a blood pressure is 90/60. Now, 90/60, 90 systolic 60, that's what we say, but the lower your pressure and you're not symptomatic is fine. Remember, you need a mean arterial pressure of 60 to stand up, but not for everyone. So if a person came in, let's say with 87/57, what I would do is take their blood pressure lying down. Then I'd say, sit up real quick. Do you feel dizzy? No. Then I take it again. Then I say, stand up real quick. Now, if they don't feel dizzy or anything, that's an okay pressure for them. The lower the pressure, the longer you can live. But however, we have defined what hypertension is. Hypertension starts with a blood pressure of 140/90. A blood pressure of 140/90 or greater is hypertension, right? So in hypertension, we have what we call primary and secondary. Now, in any case, in clinical, when you see primary or secondary, primary generally means you can't find a cause for it. It's there. Secondary means that you found something that is causing this to happen. You found something that is causing this to happen. So in hypertension, primary hypertension, there is a cause, but we don't know what it is at this point in time, and because we don't know everything about the human body. And so we call that essential hypertension. For some reason, whoever came up with that word, for some reason, the body thinks it ought to have a high blood pressure. Unfortunately, 90 to 95% of the patients with hypertension, we can't find a cause. All right. So secondary, you found a cause. Okay. Generally, hypertension is what they call the silent killer. Generally, there are no symptoms. Sometimes you may have a headache or two, but that doesn't really say anything. Okay. No direct causes in primary hypertension. Secondary hypertension. So when we do, I'm gonna come here. When we do a hypertensive workup. Now let me kind of explain this. I want you to understand in clinical, you'll know a little bit ahead of time. A workup is we do if a condition has multiple etiologies. If a condition has, we'll write that down here. Multiple etiologies. Now and I'm gonna erase it in a minute. Okay, if a condition has multiple etiologies, we do a workup. Okay, a condition has multiple etiology means cause. So let's say a person had anemia. So they had a low blood count. But there are many reasons for anemia. And you need to know why this person, what's the cause for this person's anemia to be able to treat it. So if a condition like hypertension has multiple causes, etiologies, you do a workup to try to see what it is. Okay? So in this particular case, you're doing what we just talked about, a history, a physical, some lab tests, a EKG, and so forth, to try to come up with it. Okay? So I go back to the MAP formula, which you've seen over and over again. And remember I told you this is the formula that can tell what's going on. Okay? So when we do the workup. Then what we're looking at are these various lab tests that we would do. Okay. The lab tests would include urine and blood test, EKG. You're looking at various, for secondary, the adrenal cortex. You're looking for breakdown products of epinephrine in the adrenal cortex, increased aldosterone. You're looking to see if the kidney has a problem. Remember the kidney, the renin-angiotensin. You're seeing to see if the heart is beating too fast or the stroke volume is too much. So you're looking at all of these, EKG, urine test, x-rays, test drawing blood. You're looking at all of these things to try to see if you can find a cause. Because if you can find a cause, potentially you can treat the cause, and there it is. But what did I tell you? 95% of the time, there is no cause that you can find. So we call it essential or primary hypertension. Now, so once the workup is done, if you can't find a cause, then it's going to be primary hypertension. So then what happens is we have this whole bunch of medications, but we're trying to kind of see what's out of whack. So let's just, you can read it yourself. So if the blood volume is a little high, you might give a diuretic. Let's say it like that. The blood volume, you find that is not too high because that would have been a cause, but it's a little high, still in normal range, but a little high. If the heart is beating too fast or particularly too hard, too much squeeze, too much inotropic, then you give a calcium channel blocker. I want you to go back into previous PowerPoints and kind of look at this. See, this is the kind of thing I like to do tests on to see if you know why. If the renin level is too high because there's the kidney with a renal artery stenosis, you may use this here, an angiotensin converting enzyme. Go back and look at why. Go back in your notes to see how this would help with a high renin. Here's another, now this is new, direct renin inhibitor. Obviously you can see what that is, but this is very expensive. So most people use this, but what you want to do is go back and see, why is this? What would this be? An alpha blocker. What would that be for? Well, remember norepinephrine on an alpha causes vasoconstriction. So if you used an alpha blocker, you might inhibit that. But how here is the stuff you want to do. How here would that have reduced the blood pressure? Where would it have been? Okay, then lifestyle changes. Again, medications. A beta blocker. Remember, beta 1 is on the SA node. So what would the beta 1 do? It would slow the heart down. So I'm just showing you we have a bunch of medications that we can use. We're saying that if we haven't found an actual cause, so we're having to use this and determine what to start with based upon what's kind of out of whack, but not enough out of whack to say that's a cause. Not enough out of whack to say that's a cause. Now, the problem with secondary hypertension, with a primary hypertension is, since you didn't have a cause, number one, and you're taking these medications, you pretty much are going to have to be on medication all your life, except unless you lost some weight and some other things and the blood pressure went away. See, a correlation between being overweight and hypertension is not direct, because there's some people overweight, they don't have hypertension. So the only way we would know that is if you're overweight and we tell you to lose some weight and you do, and the hypertension decreases or goes away, then that was the mitigating factor. That was the mitigating factor. So hopefully this kind of gives you an idea. You can glance at some of the material and everything like that. This is to kind of give you an idea on the counter side. And these are the kind of questions I like when it comes to more critical thinking. All right. Thank you very much.